Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. This episode features expert answers to your questions on PrEP for advanced practice providers. I'm joined by Dr. Tavell Kindall, who is a nurse practitioner and the Director of HIV Prevention and Treatment at St. Thomas Community Health Center in New Orleans, Louisiana, and Dr. Anne Teitelman, who is a nurse practitioner and an emeritus associate professor at the University of Pennsylvania and a professor at Thomas Jefferson University College of Nursing in Philadelphia, Pennsylvania. For the full online educational program, including video roundtables, downloadable slides, and other podcasts in this series, please visit the link in the show notes for this episode. Now let's get started with our first question from the audience. Robin asks, when you're talking about navigators, are you talking about using peer navigators or another type of navigator?
I can take that one. You can use a peer navigator, but you can use someone who's a professional, like a tech or a layperson or a nurse or someone like that in the clinic who could support patients in a variety of activities related to PrEP, with getting their labs, getting insurance together, helping get the prescription filled, or giving the injection. But a peer navigator is just one type of navigator, but you can use any type of navigator who might provide that role. We do think that, and there is evidence to support that if someone looks like the person they're taking care of, that they may be feeling more comfortable or maybe more likely to follow up. But I think, having any navigator is really important in advancing, making it possible for providers to provide comprehensive PrEP care.
I agree, Anne. And I'd also like to add that it's important for you to acknowledge the skills that these individuals have and the knowledge that they have and pay them appropriately. One of the things that we see oftentimes with navigators is that there's a lot of turnover because oftentimes they're just not paid very well. And one of the things that I addressed here at my agency was making sure that role was a role that was respected and compensated appropriately, so that you can have someone in the role who not only values the work that they do, but also feel valued through the compensation that they receive for the skills that they do. So I think it's very important to be thinking about that in terms of, if you really want someone who's going to do the work and do it really well, you need to pay them.
Can I add something to that? The other thing is we've heard from patients that having a consistent provider, having a consistent person to go to help them out with PrEP is really important, because, as I said before, it is a sensitive issue. Some of these are sensitive issues. And for that trust to develop over time, it's really important to have consistent individuals working with our patients. So I agree with Dr. Kindall that, having someone be respected and well paid will keep them there longer, and that will be a great benefit to your patients.
Thank you. Kimberly asks, why not mandate PrEP education for all providers?
So I guess I'll go there. So it's mandating is a very strong word. I do believe that it is a very, very important topic that we should address. And so what I have done, and I'm sure many of my colleagues who do this work have done as well, is we've taken it upon ourselves to educate those individuals, our colleagues, to make sure that they are feeling more comfortable in providing PrEP, and making sure that they feel more comfortable having courageous conversations surrounding sexual health and those kinds of things. Mandating is strong, but I do understand the importance of having that type of expertise in education. I just don't know if mandating it would be the thing to do.
All right. And then Kimberly also asks, can we build patient PrEP education into the EMR with other health prevention reminders, such as PAPs, colonoscopies, flu shots, etc.?
Absolutely. I mean, having our patients be educated about PrEP is really, really important, and makes for a much better visit with the provider and the whole healthcare team when the patient's coming in educated. In fact, we have developed a community-based intervention for PrEP, and then we try to facilitate linkage to care. And women are in much better position to have decision-making conversations with their provider as opposed to basic information kind of conversations with. So it's a better use of provider time when we can do some upfront patient education first and provide knowledge and options and describe all what's available and all that before they go see the provider. And then that would be before the visit, and then the kind of support we were talking about afterward is also really important. But that package is a really nice way to do it.
Yeah.
Right. And then Tammy asks about renal function with PrEP and then also hepatic function. What are the concerns with either of those and cutoffs for the different PrEP options?
So the package insert, as well as the prevention guidelines, do provide information as relates to the cutoffs for renal function. For FTDF, I believe any EGFR or creatinine clearance that's less than 50, then there are some concerns there as it relates to using FTDF. For FTAF, I believe you can use that all the way down to an estimated creatinine clearance of 30. For injectable cabotegravir, there is no concern there. So if you're really, really concerned about someone's renal function, if it is indicated for FTAF, then you do have the option to use it down to a lower creatinine clearance, but you do have the option of using injectable cabotegravir, should you really, really have some significant concerns about renal function. With liver function, certainly we're monitoring liver function. I have not had any issues as it relates to someone having climbing liver function tests or enzymes on any of the oral or injectable PrEP options. But I do, from time to time, get questions from colleagues as it relates to liver enzymes being slightly elevated and sometimes significantly elevated. Certainly those elevations that are, upwards of 3 times their upper limit, I think warrants certainly an evaluation and some significant questions. Is it that they're drinking? Is it that they've now acquired a hepatitis of some sort? What exactly is going on? And whereas it might be the medication, those instances are rare. Those instances were rare even in the data that we have available in terms of safety and efficacy.
Right. Robin asks, do you have a percentage of GYNs who prescribe PrEP, or what has been your experience with that?
Don't have that off the top of my head, and that would include, I would think, women's health nurse practitioners and the PAs who work in that space as well, which are a lot, but I believe it is rather low, lower than primary care. So I actually just looked at it this morning, but I can't pull it out of my head right at the moment. So that's another area where it makes total logical sense to provide PrEP as part of a healthcare package about prevention of contraception, prevention of STIs. It should be packaged together in OBGYN women's health spaces, midwives including. And it is often a very underutilized area where PrEP has been offered in that setting. So that is one area we're working on to try to improve that, both at the provider level and the patient education level.
Absolutely. And I certainly don't want us to leave here beating up on our OBGYN colleagues and our women's health colleagues. There have been reports in literature as it relates to perhaps them not prescribing as much as they should in terms of making an impact in HIV prevention. But I do believe that many of them would love to be able to offer the option and help us in terms of HIV prevention and ending the HIV epidemic if they have the knowledge and skill to do so. So we just need to be supportive.
Justin asks, has CAB-associated HIV testing at 2-month intervals affected routine STI testing? For example, many patients have HIV and STI testing every 3 months. How do you align that with those CAB injections?
I know that colleagues are doing screening a variety of ways in terms of if it's episodic, perhaps they're coming in with symptoms and they will request testing at that visit. Some colleagues have reported that they are doing STI testing basically every 4 months. So they'll get their HIV testing and injection and STI testing all together. And then the next time they come in for the injection, they only get their HIV testing and the injection. And then the next time they come in, they'll do the big comprehensive thing again. But certainly at any time when you're taking your history, when they come in to see you, you get a chance to talk to them. If there's been an exposure, perhaps new partners, multiple partners, those kinds of things, if the patients are comfortable enough to share with you things that have been going on with them since the last time you saw them, that may be the indication for you to go ahead and rescreen them again, even if it has been in 2 months, because it could very well be that something has been acquired in 2 months.
We've had a number of questions about funding. So do you know of any programs that assist with funding for patients to receive PrEP if they are uninsured? And then if they are insured, is, in your experience, Medicaid or private insurance covering the cost of medication, lab visits, everything that's needed for PrEP care?
There were patient assistance programs from some states and cities and from some companies that make PrEP. I don't know the status of those right now. They change from time to time and differ from state to state. And also Medicaid coverage also changes from state to state, whether Medicaid, depending on states with Medicaid expansion or not. Tavell, what's your experience been in your clinic down there?
Yeah, so I'm in Louisiana, so I'm fortunate in that Medicaid does cover the cost of antiretroviral therapy for both prevention and treatment. So people who have Medicaid have access to all the options for HIV prevention. Now, what that means is there may be someone who comes in who meets criteria for Medicaid, but they don't have Medicaid. So that's where the staff comes in, helping them to get access to Medicaid so that they can have access to the prevention option that they would like. For those individuals with commercial insurance, there's a percentage of the medication that's covered, unless there's one particular insurance that may not cover one or more options or different options. But I think it's important for you to have a navigator who is knowledgeable of which insurance companies in your particular state or area or whatever covers which options, and to kind of work that system to make sure that they get access to something. The pharmaceutical companies do have the copay assistance in situations for the branded products that are being used for HIV prevention. And then I'll always encourage colleagues to say, hey, look, if at all else, the FTDF is generic and is likely to be really, really cheap. And so if affordability is an issue, then that is an option that is still safe and efficacious and affordable.
Gina asks, I work with patients who are detained with U.S. Immigration and Customs Enforcement. Many times they do not know where they will be residing upon their release. We want to consider prescribing PrEP while they are in custody, but the follow-up is an issue. Is there a PrEP hotline, warm line, or a similar resource that we could provide to patients so they can easily contact someone once they are released to assist with them in continuing PrEP?
Oh, wow. That's a good question. Off the top of my head, I can't say that I know of such a resource, but I would imagine maybe doing a Google search to find something that may be out there could be helpful. I do recognize that challenge. You want to get them something that helps to keep them from acquiring HIV, but then it's like you're going to hand them off to somewhere else. But it may be difficult to know where to send them when you don't know where they're going. So that can be a pretty significant challenge. I'd like to follow up a little bit more on that and do some research myself and see what to do in those kinds of situations. Thanks for the question.
Yeah, some cities and states, public health departments have listing of PrEP providers who are PrEP friendly. I don't know if there's a national listing, but there certainly are many states and cities that have those kind of listings available on their local websites.
Sharon asks, can you explain on-demand PrEP further?
So these individuals, the acronym is 211. So they'll take 2 tablets prior to their sexual experience, and then one tablet each day following, depending on the period of time when they're going to be most sexually active. And after that time, when, if they're, I guess, done, and, perhaps, this was something that they plan, like they're going to be sexually active for a certain period of time, they will do this for that period of time. And then once that period of time is over with, then they are not needing to take the medication. And they'll have medication likely on hand for another experience. And so whenever they get ready to do another experience, or they'll do the same thing, they'll take 2 and then 1 and then 1 each day following to prevent HIV infection from occurring.
Okay. And then Nicole asks, how do you discontinue PrEP if a patient wants to be off of it?
So that's a good question. It's certainly a thing that can happen because, patients they do have the option to stop, at any time when they get ready. So I think definitely having a conversation, having a plan with them about how to discontinue PrEP. And there is some guidance as it relates to, screening in terms of, once they stop, making sure they understand that when may no longer have any protection as it relates to detectable drug levels in their blood and tissues, I think is important. And it becomes a challenge in saying, hey, look, you're going to lose protection in this period of time once you stop PrEP. I don't know that has been a thing that has been clearly defined, but I think it's important for, you to have that conversation with patients, say, hey, look, if you're stopping PrEP, let's make sure you're tested, let's make sure you're negative, and let's talk about what our plan is to keep you from acquiring HIV now that you are no longer on PrEP. Also, making sure that they understand that if they change their mind and want to go back on PrEP, so long as they remain HIV negative, they do have that option. So it's not like, if they stop, that's it, they don't have the option anymore, unless they become HIV positive, and then they no longer have the option for PrEP. But just having that conversation with them, I think is most important, making sure they understand that screening is still recommended. The frequency of the screening would really be driven by, behaviors and exposures, and make sure that they know that they can access it again if they choose, so long as they remain HIV negative.
And if it depends also on the reason for stopping PrEP. For instance, if someone wants to become pregnant, and cabotegravir has a very long half-life, and it's also, we don't yet have the research about cabotegravir and pregnancy, so it's sort of in a gray zone in terms of being recommended during pregnancy. It's not generally recommended during pregnancy. So if someone's maybe thinking about being pregnant in a year, that may be something to think about, like when might they stop cabotegravir in order to try to clear the cabotegravir from their system before they try to get pregnant. So that might be part of the upfront conversation to have with somebody, is how long they might want to use it, what their other plans are, and in terms of pregnancy, and if they're capable of getting pregnant, and planning that in initially when they get started.
Thank you. And regarding finding PrEP providers, AJ said that preplocator.org is a great resource for this.
Outstanding. I'm sure that you could probably Google something. I'm sure it's something out there. So thanks so much for sharing that resource.
Yes, thank you, AJ. Rebecca asks, can you please talk about potential side effects with PrEP?
Basically, with the oral method, the side effects are pretty minimal and short-lived, and usually they go away within a couple of weeks. Usually a little GI distress is the most they'll have. And with the injectable cabotegravir, the major side effect has been injection site reactions, but that's getting managed much, much better than it was initially. Tavell, do you have any more information from your clinical experience there?
Yeah, as it relates to renal and bone, I think the most important thing for advanced practice providers to know that these are rare occurrences. Like, I think sometimes providers are afraid. They're like, oh my God, I'm going to mess up somebody's kidneys, or they're going to have bone issues. They're going to have fractures and not. No, like those are rare incidences, and they're going to be in your care, and you're going to be seeing them very frequently. So you will see some changes sooner, much sooner. And if you do see something, then you can address it. But it's unlikely that you're going to see something that's going to be so significantly a problem that you're going to have some major thing to happen. You do have for the oral options, for those individuals who are younger or those individuals who are older and have other comorbidities, if they meet the indication for FTAP, that is a consideration when you're thinking about competing renal stuff and perhaps, bone mineral density changes with aging, or perhaps someone who is younger and still laying down bone. Those are thoughts, those are considerations. But, it's still unknown. We still need more research to really, really support if one option is better than the other. For FTDF, again, it's efficacious and it's affordable, and you're monitoring them. And so if nothing's happening, it's something to continue. And so long as the risk for HIV acquisition is still there, I think that's something, to really continue to provide for them so long as they're not having any issues. Dr. Teitelman did mention, the GI upset. Sometimes we do see that. Just encouraging them to take it with food has been one of the things that's been most helpful for patients in my clinical experience. So look, you make sure you got something on your stomach, especially when you're first getting started, just to kind of ease that transition. And some individuals, they're able to do it and not have any stomach issues or whatnot, and they're fine. So, I think it can be individualized too. If there are any other specific side effects that you have some concerns about, we certainly welcome you to ask those. But those are the ones that are most common: renal and bone and what lipids. And knowing that there are options that, depending on what's going on, you have options to switch if needed.
Ella says, anybody who wants PrEP should get it, right?
Yes. Part of it is, as I was saying earlier, the conversations about the old guidelines suggested that providers needed to assess risk and provide it only for those who are at high risk for acquiring HIV. And that put everyone in an awkward position in that you felt like you had to do an investigation about someone's behaviors to make sure they were eligible for PrEP. As I mentioned earlier, not everybody wants to reveal all those details about their lives, but they may very well know that they could benefit from PrEP. And I think if they know what the indications are and they say they want PrEP, they should get PrEP.
I agree.
All right. And I'm going to combine these next two questions. Sharon and Leslie ask about the best way to educate primary care providers to encourage uptake of PrEP discussion and prescriptions, and resources that you might recommend on how to prescribe PrEP medication.
I think for my primary care provider colleagues, I'm carved out in my agency as the director of HIV prevention and treatment, so essentially a specialist, but I support all of my primary care colleagues across the agency in their efforts to provide PrEP, and all of the primary care providers where I work do prescribe PrEP, and we're very proud of that. But, just having the support and having the knowledge definitely brings about comfort, and having you're more comfortable doing it. And then once you get going, you realize that it's really not that easy. But we mentioned before, you're able to wrap prevention services in your other health encounters. I think that's one area where primary care providers can really flourish. You're having someone to come back to see you every 3 months or perhaps every 2 months, depending on whatever option that they're using. But you can capitalize on a whole bunch of health promotion and disease prevention types of activities, address anything as it relates to their risk for hypertension, diabetes, obesity, smoking, substance use disorder. All of it can really, really help you to, in terms of really, really addressing many health issues, not necessarily just preventing HIV. Knowing the resources that are out there for education and training, the guidelines are available, and then just partnering with a colleague who is more experienced in doing it, and they will help you to see that it really is easy, and you can really, really be making a significant impact in ending the HIV epidemic by preventing new infections from occurring in the first place.
And I would just add, it's wonderful, Dr. Kindall, that you're a champion. That's a great model to have somebody in the practice who is a PrEP champion and takes on that role and then spreads that information throughout the clinic and whatever setting you're in. And I just want to put a shout out for this particular program. This one in particular is for advanced practice providers. but there's a whole lot of resources for providers in general. And then the CDC has a lot of great information, and not just the guidelines, but talking points, information, printouts to give to patients that are at a, sort of generalized literacy level that are very easily accessible and understandable. So there are a lot of resources out there that you can use to build up your own knowledge base and to share with your colleagues.
Gina says, is there any evidence that someone who is on and off of PrEP could cause drug resistance?
So, there is a concern as it relates to resistance to one or more of the medications in the oral prevention options, or for someone who may be on, not necessarily on and off, but I think it's more in the setting of if they actually acquire HIV and not on what would be a complete regimen with another agent that's working in the HIV life cycle, to stop the virus from making a copy of itself. I'm not so certain if someone being on and off PrEP would be a challenge for resistance, because HIV is not there in that particular setting. But I would love to hear if there are any other comments as it relates to that.
The other thing about going on and off PrEP too is that many people, particularly for the oral formulations, find it difficult to take a pill every day, and their coverage is a little less than optimal. And that could be one way they might acquire HIV. But, if they do get HIV, fortunately, there's an array of other medications that can be given to treat their HIV. It's workable.
For those individuals who are on and off, there's a potential for them to have subtherapeutic levels of medication in their system at the time that they may be exposed to HIV. And in that setting, perhaps HIV resistance is possible. But for them being on and off and not acquiring HIV, I think that was the point I was trying to make. I think, because patients have options, they can stop if they want to stop. And so you can't just share with them that, oh, no, you can't stop because you're going to,
The other point that I think that I know we've emphasized PrEP, but there are other ways of preventing HIV. And part of what we do when we talk about PrEP is to discuss all the other options that we've been talking about for years before we had PrEP. So I think it's a package, and people have choices about how they want to prevent HIV and other STIs. And at different points in their life, they may want to use different options.
Thank you very much to our faculty, and thank you to our listeners for joining in. As a reminder to view the full paths forward in PrEP, Overcoming Barriers to PrEP Engagement in Principal Populations program, on the Clinical Care Options website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.